adrenal gland, we'll talk about adrenal insufficiency, and we'll talk about Cushing's. So with adrenal insufficiency, it can either be primary or secondary, and that depends on if it's something from within the adrenal gland itself or if it's within the brain, as in the hypothalamus, or more likely the pituitary. So we'll start with primary, and here you're going to have a more severe presentation in general because you're losing both the mineral corticoids and the glucocorticoids, and that's a fact that you should keep hard in your brain because that's going to help you understand the etiology, maybe save you some time thinking about it. So somebody who has signs of shock and signs of cortisol deficiency more likely has a primary intrinsic adrenal gland problem. And the presentation of this is usually brought about by an infection or surgery, some kind of stress in the body, and the adrenal gland can't mount the response it needs to actually match the necessary cortisol requirement for the body. But these people usually have this going on for a while, usually due to an autoimmune cause, and that would be the most common etiology overall, which is just autoimmune adrenalitis. That being said, tuberculosis can also be a sort of a long, lingering cause of progressive adrenal insufficiency in these patients, or the cause for this could be an acute insult in general with a hemorrhage due to maybe Waterhouse-Friderichsen syndrome or a trauma injury. And the key here again is going to be to have signs of both loss of mineral corticoids like low blood pressure and low sodium with high potassium, and also you're going to have diffuse abdominal pain. This is actually relatively specific for primary adrenal insufficiency versus secondary insufficiency, is to have this diffuse abdominal pain. They should also have some nausea and vomiting. And another clue would be if their skin is hyperpigmented, that suggests that the pituitary has been trying to get the adrenal gland to work for a while to no avail. And then if we talk about secondary AI, now we're going to look at somebody who maybe has been getting medical, steroids. And this could be even skin steroid cream, or it could be inhaled steroids for COPD. It doesn't matter. Any source of chronic steroids can ultimately lead to suppression of the adrenal axis once you take away the glucocorticoids. And that's something that I didn't mention here, but I think you all likely know by now. In general, more than a few weeks of steroid therapy followed by abrupt discontinuation is going to put someone at risk for adrenal insufficiency. And again, notice here that the blood pressure symptoms, you'll still have some blood pressure hypotension symptoms, but that's going to be much less severe, and it should not be shock. And I put in here for you guys to just, maybe in case you wanted some basic science knowledge, that cortisol is actually needed for ADH action on the vascular tone. So without cortisol, you do have some inherent hypotension in general. And again, the electrolytes here should be normal. They should have a normal sodium and a normal potassium, whereas in these primary patients, they should have hyponatremia and hyperkalemia. And likely they should also have a an acidosis as well. So then when you're trying to diagnose this is really probably the most important thing, is the cosentropin stimulation test. That's what I really want all of you to take away from this lecture, is that you don't measure a serum cortisol to diagnose adrenal insufficiency. You have to start with a cosentropin stimulation test, which is annoying because it's really just ACTH. So I'm not sure why we can't call it that, but we have to deal with what we're given here. Idea being that if you give ACTH, that should stimulate the adrenal gland to produce cortisol. And if it doesn't produce cortisol, then you have adrenal insufficiency. Now, after you've done that, you need to measure the ACTH level in the serum. And once you've done that, you are one step closer to figuring out what the cause is. One thing I put in here that is probably not going to be tested, but is something that I've heard people talk about and maybe seeing, and it's just one of those testable topics that you should be aware of that exists. This drug called metirapone, blocks cortisol production by the adrenal gland. So hypothetically, you give this drug and the pituitary should lose feedback inhibition and create more cortisol in response to the drug. So a failure of ACTH levels to rise after giving this drug would suggest secondary adrenal insufficiency. But again, I doubt they're going to use that on you. but you need to know that the cosentropin stimulation test is the way that we diagnose adrenal insufficiency. Then, if we find that somebody has a low ACTH and they have a low cortisol, we think they have secondary AI. First of all, you want to look in the question and make sure there's not some obvious reason that they've been getting chronic steroids like rheumatoid arthritis or lupus or, COPD, you name it. And if there's not, then the best answer to the question is probably to do a brain MRI in order to evaluate the pituitary for a cause. And I thought while we're here, it'd be a good time to review some of the major pituitary pathology that you might be tested on, because unfortunately some of this stuff does make its way onto the medicine shelf. So the most obvious reason is just a plain old pituitary adenoma, and you'll have that bitemporal vision loss, and you'll probably have more than just adrenal insufficiency. You should also see some hypothyroidism, and if it's a girl, you'll see some oligo, loss of the period. They might have nipple discharge, loss of interest in sexual intercourse, and for a man, they might have gynecomastia, and hypothyroidism is probably going to be present as well. So these questions get pretty challenging because you have multiple endocrine abnormalities at once. And if you're asking yourself, oh my goodness, this is a paragraph long question, and it looks like they've got adrenal insufficiency and they've got a loss of a bunch of other hormones, then I imagine you're probably dealing with a central loss of pituitary hormones. And pituitary apoplexy is an important diagnosis for you to be aware of. And this is somebody who's actually they've had an adenoma, and it turns out that the adenoma gets so large that it either infarcts on its own or it hemorrhages. And the key here is an acute presentation. They have a massive headache, and they're going to have vision changes. And apparently those vision changes are likely to be bitemporal peripheral field defects, just like with an adenoma. And the changes from the endocrine axis should be much more acute as compared to the adenoma itself. So these people might have, acute low blood sugar and low thyroid hormone levels and stuff, but the key here is that rapid onset of headache. And they may even have increased ICP and may require a craniectomy, but that's probably not going to be the kind of detail they want from you. And Sheehan syndrome is actually an OBGYN topic. However, those topics make their way onto this shelf as well. And similar kind of pathology here, during pregnancy, your pituitary gets real big, and so big that if you hemorrhage during pregnancy, and if you watch a C-section, there's a lot of blood in any C-section, that can be enough to cause an infarction of the pituitary gland. And the key to the diagnosis here is going to be maybe some AI or hypothyroid, but the key would be that a woman who wants to breastfeed can't make breast milk. All right. So tuberculosis is a cause of Addison's disease. It's something that you should be aware of, and I'll try and talk about it more whenever we do some infectious disease stuff. But for now, if you have somebody who, like we said, maybe has an adrenal crisis, and you're looking for the underlying cause, then maybe a CT scan with bilateral enlargement with calcifications would lead you to suggest that maybe this is tuberculosis. But these patients should also have other signs of pulmonary or miliary TB in the question. So just be aware that TB can come in and infect the adrenal glands. And for your information, that's not the only thing that causes Addison's disease from an infectious standpoint. It's just something that I think you're more likely to be tested on. Then with adrenal gland hemorrhage, or as it's called sometimes, Waterhouse-Friderichsen syndrome. This is actually a very good high-yield topic to be familiar with. So we're talking about Neisseria meningitidis here, and patients may have the URI syndromes and symptoms initially. They may have headache and neck stiffness because they have meningitis, but then they become septic with the meningococcus, and that's when you start seeing chills and rigors, and they ultimately, due to all the endotoxin, develop DIC, and DIC can cause bleeding anywhere. And with these patients in particular, there is a preponderance to have bilateral adrenal hemorrhage. And that's when you're going to see, in addition to the signs of sepsis and shock, they have low sodium and hyperkalemia. That should throw you off right there. That's not part of a normal sepsis picture, and it sounds like adrenal failure. And the management here is going to be important for you. You want IV ceftriaxone for the gram-negative encapsulated organism. and you also want fluids because they're acutely hypotensive. And ideally, if their adrenal glands are not working anymore, we want to replace them with steroids. And just be aware that trauma, maybe from a car accident, if you break the ribs, especially the lower ribs, that could cause an adrenal hemorrhage and an acute crisis. And I'm not sure how they test you on this, but I did read a bit that people with hypercoagulability, maybe from an inherited thrombophilia, may have a tendency to thrombose the adrenal vein, and if that backs up enough, it can actually cause an adrenal hemorrhage and crisis. So now we'll move on to too much cortisol with Cushing's syndrome, and diagnosis of these can be a bit more complicated. And Cushing's disease is when we talk about a pituitary mass. So syndrome could be the umbrella term that applies to any cause of too much cortisol, whereas Cushing's disease is specific to the pituitary. So then syndrome, that could be an adrenal mass, or it could be, a lung cancer that's producing ACTH, or it could be us as physicians giving out too much steroids. And then the signs and symptoms, I think, are usually relatively clear in the question when they're giving them to you, although they are fairly nonspecific for the most part. But one thing I want you to keep your eye on is anytime you have increasing severity of something like hypertension and high blood sugar with resistance to insulin, that would suggest that this patient is actually Cushingoid. And then some of the more specific findings that can help you diagnose this are the striae, those big purple things that look like stretch marks, the plethora or the moon face, and if you're lucky, the exam question will give you something about proximal weakness and atrophy of the muscles. And something that you may not be familiar with, but I'd recommend knowing, is that this can also cause osteoporosis due to increased bone catabolism, essentially. Same kind of thing happens with hyperthyroidism. And so how do we diagnose Cushing's disease? It's technically you need 2 out of 3 screening tests to confirm the diagnosis. I don't know how they test you on that, however, so I'd just be aware of all 3 tests. The best test that I think you should be aware of is the low-dose dexamethasone test, where we measure the cortisol the morning after giving the low dose, and it should be, negligible or suppressed. And if it's not, then, we have a positive increased cortisol and Cushing's. So once we have a positive low-dose dexamethasone test, we need to figure out what is the cause. And from there, we have to do a high-dose dexamethasone test. We actually don't have to go straight to that, because if we have a low, or if we have a, let's say that we have a low ACTH with increased cortisol, that would suggest that the pituitary is functioning appropriately, not secreting ACTH, whereas we have an adrenal mass that's making lots of cortisol. So low ACTH with an increased cortisol from the screening, as I just mentioned there, is going to be enough to diagnose an adrenal source for your Cushing's syndrome. And the next step after that would be to do a CT scan in order to figure out if there's an adrenal adenoma or carcinoma, and then to probably remove it. So let's say that your ACTH level comes back high, and that suggests that you have an ACTH that is, causing your Cushing's syndrome. And that's when we have to do the high-dose dexamethasone test. And that helps us figure out where the source of our ACTH is. And one thing I want to point out again is that you don't do a high-dose dexamethasone test initially. You have to do a low-dose test first, and a high-dose test is only done when we need to figure out where the ACTH is coming from. So with the high-dose test, if the source is from the pituitary, it's going to be suppressed. So low ACTH after the high-dose test is going to confirm that we have Cushing's disease. However, if we did the high-dose test and it's still not inhibited, then bingo, this is an ectopic ACTH, and it's probably small cell lung cancer, and you should probably do a chest CT to diagnose a lung cancer. And if they did do a high-dose dexamethasone test, I'd be aware that the adrenal masses that are producing cortisol would also not be suppressed by high-dose dexamethasone. So then how do we manage these different sources of Cushing's syndrome? Kind of like I just mentioned there, if we have a ectopic ACTH, it's probably small cell lung cancer. We're going to need to evaluate for a lung mass. And If we have a pituitary source, sort of like before with AI, centrally, we're just going to want to do a brain MRI and see if there is a ACTH secreting pituitary adenoma. And if there is, the management for that would likely be surgical removal. And then lastly, if someone happened to have low ACTH and we think that it's an adrenal adenoma or carcinoma, the first test is a CT scan, ultimately followed by surgery. So the last thing we'll go through here is increased aldosterone secretion. So this is actually a relatively more common source of hypertension than you'd think, about 14% according to what I just read. But it's somebody who has high blood pressure that has just not responded to medicines. And you look at their electrolyte panel if they give it to you, if you're lucky enough, and their sodium level's normal, but it's probably at 143 or 144, pretty high normal. And the potassium level is probably 3.5, right there on the low cusp of normal as well. And that to me would suggest that you might have an increased level of aldosterone. And remember, there's an aldosterone escape phenomena where when you have chronically elevated aldosterone, your electrolyte abnormalities are actually not going to be abnormal. And then if you want to screen for this disorder, you do the renin-aldosterone ratio. But again, that does not confirm the diagnosis of hyperaldosteronism. But a ratio greater than 20 is suggestive enough that we can do actual diagnostic testing. So the diagnostic test of choice to confirm hyperaldosteronism is a saline suppression test. And you just give IV saline, and apparently that should make the aldosterone-renin ratio go to normal. So if it doesn't, you have hyperaldosteronism, and that should be coming from the adrenal gland. So we want to do an adrenal CT, and if it's an adenoma, we're going to take it out. But if it's bilateral adrenal hyperplasia, the best next step would be to give spironolactone. And that specifically, I know there's other aldosterone antagonists, but everywhere that I've read, spironolactone is the drug of choice if you want to medically manage hypertension due to increased aldosterone.